Welcome everyone to the Commission on Excellence and Innovation in Health Next Improvement and Innovation Showcase Series for September 2025. My name is Tina Harden and I'm the Executive Director of Clinical Informatics and Innovation at the CEIH, as we like to call ourselves for short. This series is all about creating excellence by reducing unwarranted clinical variation. I would like to start by acknowledging that the land that I'm on today is the traditional lands for the Kaurna people and that we respect their spiritual relationship with their country. We also acknowledge the Kaurna people as the custodians of the Adelaide region and that their cultural and heritage beliefs are still as important to the living Kaurna people today. Before we start, a little bit of housekeeping. So we ask that you keep your cameras off and your microphones off. We've deliberately preset that in the presentation for you, just so that the presenters can have a nice smooth time of going through their presentations. The presentations will be recorded and made available post the showcase session. And when we get to the Q&A session at the end, we'll stop recording and you'll be able to turn your cameras on, put your mics on, and we'll get into some really great discussion. But just to reiterate again, we won't be recording those bits. If you have a question in the meantime, please feel welcome to pop it into the chat. I know what it's like when you've got a question as the presenters are going and you don't want to forget what it is. So please feel welcome to make sure you just pop it in the chat, but we'll get to that at the end of the presenters. We'll also, at the end of the presentations, just before we get to the Q&A, there will be a survey, and we do encourage you to do the feedback survey because, of course, we can't keep bringing you these great showcase series without your feedback. And at the CIH, we do believe in evidence-based decision making. So if we've got your feedback, we can follow through on that. Right. All about the CIH. So our vision statement at the CIH is together creating health and prosperity for all. We are a lead agency for healthcare in South Australia, and we love bringing people together, hence the showcase series. So whether you're a consumer, a clinician, or other collaborators, we want to bring you together to turn ideas into better healthcare. And we do this to support the health, to imagine new ideas. And we also acknowledge that better isn't always excellent, but we're committed to measuring what we do so we can understand the impact of the change we're having. The Improvement and Innovation Showcase is all about what are the big ideas, we're connecting the small ones. So we bring you 40-minute sessions online and then make them available so that you can access them whenever. It's all about bringing you, our healthcare community, together and providing a space for us to explore, share and learn and collaborate from others. We want to keep it simple because we actually have quite a diverse audience from all kinds of different backgrounds and experience and perspectives. So we want to make sure that the information we're sharing is in the true spirit of collaboration and that we're bringing all those perspectives together, but actually making it accessible as well. We focus on South Australia, but every now and then we like to share our showcase outside of the state and bring people from outside of our state in to ignite ideas. If you've got a story to tell, have a problem to solve, or one that you've succeeded in solving even, and you've learnt something along the way that you think is important to share, please get into contact with us. We are always working on creating new ideas for the Innovation Improvement Showcase, and we welcome things that are of value to you, that have impact for you. And if you've got a story to tell, we would love to hear it. As we travel around the other states, more and more we realise that South Australia has such a rich and amazing story to tell, and we don't often share it enough with other parties. So we really encourage you to do that. And there's our contact email address down the bottom, cih@sa.gov.au. So into this Innovation and Showcase series, I'd like to introduce the theme, and this is actually our 16th series for the Innovation Improvement Showcase. So we're getting quite a few under our belt now. And this one is, as I said, creating excellence by reducing unwarranted clinical variation. Clinical variation, whether warranted or unwarranted, arises when healthcare practices or outcomes differ from evidence-based standards. Reducing unwarranted clinical variation is critical for improving patient outcomes, healthcare equity and system efficacy. Hospitals and healthcare systems use various methods like key performance indicators, audits, deep dives, and clinical registries to monitor data and identify areas of concern where variation may be occurring and what can be done to address it. That is what we are hearing about in this series, where variation has been identified and how clinicians are addressing this to improve patient outcomes. So from emergency department to ward, clinical variation in frontline care. So this is our first of highlights for this showcase today. And we also have upcoming episodes, so on the 17th of September and the 24th of September. If you haven't registered already, please take a screen shot on your phone of the QR code. And we're very excited to have on the 17th of September, Timothy Kleinig and John Beltrame talking to us about clinical variation in stroke and cardiac care. And on the 24th of September, Simone Barry from the Central Adelaide Local Health Network talking about advancing equity in APY lands, clinical variation in remote tuberculosis care. So again, please make sure you register for those if you haven't already. Right, into today's episode. We have CALHN, the Central Adelaide Local Health Network Emergency Department's leading evidence-based practice in SA. And I'd like to welcome Daniel, Sofia and Danieka Marshall to do this presentation. So Daniel Sofia has been working for CALHN since starting as an AIN in 2006. Daniel spent the first 10 years of his career in the ED at the Queen Elizabeth Hospital with a short sabbatical to work in London at St Thomas's Accident and Emergency Department. Daniel then worked as a clinical nurse educator and then nurse educator at QEH and the Royal Adelaide, with portfolios including graduate nurses and general medicine and geriatrics. Daniel then returned to the QEH Emergency Department in 2022 as a nurse consultant role and is now one of the advanced nurse unit managers and is currently doing his Masters in Health Administration at Flinders University. Good luck with that one, Daniel. And Daniel was joined by Danieka Marshall. Dani is a nurse educator at the Royal Adelaide Hospital Emergency Department, bringing over a decade of experience in emergency nursing. Dani has worked in both clinical and leadership roles in the emergency department, contributing to emergency nursing practice and informing development of clinical treatment pathways. Dani holds postgraduate qualifications in both emergency nursing and nurse education and is passionate about fostering clinical excellence, delivering outstanding patient-centred care and supporting professional growth of ED nursing staff. Over to you.
And thank you very much for having us. Before we go ahead, whilst you'll be hearing from Daniel and I during our presentation, I would also like to take a moment to acknowledge our colleague Megan Frankenfeld, who worked very hard with us on this project, and we wouldn't be able to get to where we were without her support and assistance as well. So just to provide a little bit of a background about the clinical variation that we've addressed, and for those who may or may not be familiar with emergency department processes, the nursing assessment document utilised in EDs across SA has been in place since the implementation of the Sunrise EMR. So it's utilised after a patient is triaged to perform a thorough initial assessment and determine relevant history on why a patient's presented to the ED, which then informs critical treatment pathways and essentially the progress of their journey there onwards. So how this assessment is performed in clinical practice and then documented has been highly variable previously, and that's even despite specific education on how to perform a really thorough assessment on a patient presenting to the ED, which has variability in itself depending on which educator then teaches those sessions. The document also and the nursing assessment also provided minimal guidance for novice nurses on how to assess patients in the ED. So previously, novice nurses were kind of expected to come to an emergency department and either pick up immediately how to assess a patient or, you know, take a little bit of time to develop those skills around assessing a patient. So for most Clinicians who are here today, you're probably familiar with the ISBAR handover tool. So previously the Sunrise document was actually structured based on the ISBAR clinical handover tool, but there's not actually evidence to suggest that that is the right tool in performing an assessment for patients presenting to the ED. So Daniel, Megan and myself attended numerous conferences where we were hearing about the importance of a framework called HIRAID as a nursing assessment framework, and we also were able to hear about the fantastic evidence that was coming out from some of the research surrounding the implementation of HIRAID. So HIRAID is a tool that has been developed in Australia by ED nurses as a patient assessment framework and is for use in Australian emergency departments, although is starting to be expanded into the aged care sector, and they are looking at implementing it in other areas as well. So HIRAID refers to the stages of the nursing assessment framework. So history is obtaining a history from your patient. Infection risk is involved in that history as well. So it's really important to gain an understanding of whether there is the risk of infection and then what that might do to inform care there onwards. Identifying red flags as well, which can indicate whether there is an urgent need for earlier interventions or perhaps escalation of care. Assessments, which is the assessment that the nurse will then do with the patient, which then informs the interventions and the diagnostics that are performed by nursing and medical. So HIRAID is the result of years of focused emergency nursing research in Australia, and it's the only validated framework designed to support emergency nurses in assessing and managing emergency department patients after triage. So the research so far around HIRAID has demonstrated that it improves emergency nursing assessment, therefore reducing variation in care. It also improves recognition and escalation of clinical deterioration. It improves pain management, patient experience, communication during clinical handover and during other interactions, and also increases access to meaningful treatment in a timely manner. So whilst we didn't necessarily do any particular auditing or anything pre-implementation of HIRAID, what both Daniel and Megan and myself observed between the two sites was that the HIRAID or the pre-HIRAID documentation didn't actually reflect the skilled assessment that nurses should be undertaking. And when we were looking through that documentation, we were also finding that at times it was quite poor quality as well. So HIRAID really embeds a quality assessment and components of assessment into the framework for every patient and for every nurse. So that's really important for patient care, as it doesn't matter whether the nurse that's caring for you has worked for 1, 5 or 20 years, you should still have access to the same quality care through a comprehensive assessment. So HIRAID itself, fortunately, was heavily developed package already. So there really wasn't too much work on our end in terms of developing education and training resources. We really just had to kind of lift and shift the training resources that were being used in New South Wales and Victoria. But what we did identify was that right from the outset, we really needed the right environment to be able to document in a way that reflected our HIRAID assessment and was really clear in what assessment had occurred. So we were quite fortunate to have a critical contact within the Sunrise team, which meant that we connected and partnered quite early on with the Sunrise EMR build team. In terms of the design process that we used to develop the HIRAID document, it was a little unconventional in that we initially actually used Canva to design the ideal template that we would be wanting in terms of a nursing assessment. And then we were able to share that with the EMR team so that they could fully visualise and understand what it was that we were asking for and what that document then might look like. So during the process, we also had involvement from the Consumer Representative Committee. It was brief involvement, but we were able to at least gather some feedback on their opinion in regards to HIRAID and the document that we were building. So some of the changes that we made to the document were both in line with HIRAID principles, but also surrounded some of the feedback that we had from the consumers, particularly around, we included some questions very early on in the HIRAID assessment around language barriers and potential hearing impairments, because what we know is that if we don't perform an adequate history on our patient, then that kind of doesn't really set up the whole HIRAID framework in the way that you need it to. So it was important that we knew if there was a barrier in communication or a barrier in obtaining a history, that we could try and reduce that very early on. The template we also co-designed with the Women's and Children's Emergency Department, just to make sure that there was practicality for them in the paediatric environment, and making sure that we had included components of minimum paediatric assessment. So for example, in the adult world, we're very focused on doing a GCS or a Glasgow Coma score as a baseline when a patient presents to the ED, but that is not something that they do in the paediatric environment. So what assessment tools did we need to have within that document that would also be applicable and usable in the paediatric environment as well? Over to you, Daniel.
Okie dokie. So our next steps then were implementation, and implementing HIRAID, we kind of like, there was a lot of work that was involved in implementing HIRAID, but there was, 3 kind of overall strategies. So when Danny and I had reached out to Kate Curtis and Julie Constantine about how we, go about implementing HIRAID, they really impressed upon us that it was really important to get senior leadership endorsement and support for the project. We thought that we needed to get EMR build happening first, which was really important. But getting the senior leadership endorsement and support was really important because it gave us a bit of a driver and some strategies behind the scenes to keep pushing HIRAID along, from that perspective. So that was really good, and we were very lucky that we had early support from our senior leadership team and CALHN executive. They thought it was a really good idea, and they were really happy that both CALHN and emergency departments were working together. We also reached out to the CIH for some advice and support to get some senior leadership support. Our strategy initially for engaging with the CIH was to help us, work with the EMR to prioritise our build. Then the CIH really enjoyed the idea and then took it around to the rest of the state. So that was a kind of unexpected surprise for Danny and I, but it's been a really, really enjoyable process. So we worked with EMR, as Danny mentioned in the previous slides, and then we did a lot of work with developing the training. So we had the training package given to us already by the authors of HIRAID, and had a really sound evidence base using Bloom's taxonomy and the theoretical domains framework to guide activities to support some sustainable behaviour change. The CIH were able to support us with setting up some training workshops for our local champions. So these training workshops were delivered by Professor Kate Curtis and Julie Constantine, who are 2 of Australia's top emergency nursing researchers who came to Adelaide to lead those workshops, which was really exciting. And then we developed a training plan for our LHN. Danny, Megan and I were really keen that we did it together and that we were able to launch HIRAID together across both sites, so that we were doing the same thing across sites, and then so that it meant it didn't matter which ED that you presented to within CALHN, you would get the same assessment. We capitalised on Christmas when people when the organisation tends to stop sending emails and priorities around, and we were able to get through some of our training and stuff there. So I got an example of the timeline up on the slides. The other strategy that we worked on was our supporting materials. So both sites worked on updating their treatment in progress pathways to align them with the HIRAID framework, so that when people are using HIRAID on the floor, they look at their treatment in pathway guidebooks and they're set up in the HIRAID framework. And we also worked on some departmental and LHN comms. So yeah, and then on this slide, So that wheel there is the behaviour change wheel, which is one of the aspects of the theoretical domains framework. It's really interesting, and if you're looking at doing some a change or wanting to change the way that people work, we can thoroughly recommend having a look at the theoretical domains framework and how you can use that to embed, some sustainable behaviour change. And yeah, there's one of the research articles that have come out with HIRAID, and there's a couple of photos of some of the workshops we did. So we've got one photo of the workshop at the RAN, another photo of the workshop at the QEH. So what have been our outcomes? So in January 2024, both CALHN sites went live with using HIRAID. So that was a really, really exciting time. We're still undertaking our full evaluation. We normally would have had it done a little bit quicker, but then the QEH opened a new ED, and Danny and Megan were lucky enough to be able to expand their family. So we're working through our evaluation, but we've had some of our early evaluation has shown some increased confidence, particularly with our novice nurses in undertaking assessments. The HIRAID framework has been really good at supporting the new to the early career emergency nurses with a framework that they can then go and approach their workups. We've got HIRAID leads in each site, which have taken on the documentation quality as projects, with improvements being developed by them, which I think is another further demonstration of how we've been able to sustain it. 2025, so it's an SA Health-wide project that's been coordinated by the CIH with some statewide train the trainer workshops. Danny and I were lucky enough to be invited to Launceston last month, being part of the review of the HIRAID training to, examine how we can make it sustainable. And excitingly, we're going to be able to be, in South Australia running our own train the trainer workshops, so that South Australia, will just be able to maintain our own pool of HIRAID trainers in South Australia, which will be really good. And it also then increases the cross collaboration between LHNs, as our regional and rural colleagues are able to link in with metro sites to, develop HIRAID trainers, which is really, we're really excited about. So finally, our key takeaways is, so what we learned from this process. Danny, Megan, and I did this kind of rollout within our own project, within our own FTE, and we wish we'd kind of advocated for a little bit of FTE of dedicated project time, or being able to shuffle our priorities around to give it some project time, particularly with the evaluation. NALHN in particular have took this lesson on, and NALHN are about to roll out HIRAID and have had some really early successes with their evaluation. Danny and I also learnt how to do an elevator pitch, and I think that's really important with a project like this. Luckily, HIRAID is very easy to sell because it just makes so much sense. It's a validator tool developed for emergency nurses by emergency nurses. And I think it's important to note that projects like these need someone to take it into their heart and love them. So yes, and the other thing we wished we'd done a little bit more was a little bit of forward planning for leave and all that kind of stuff. But this is it's the first big project that Danny, Megan, and I had done. So we've taken on those learnings. But overall it's been a really positive thing. We're really excited to see HIRAID in CALHN EDs, and now but before the end of the year, all South Australian public emergency departments will be using HIRAID, which is a really, really big achievement. That's all.
Fantastic work, Danny and Daniel. Well done. So I'd like to welcome Dr. Toby Gilbert, talking on data-driven dialogues, a look at the GenMed project. Now, I do have to declare a quick conflict that I also, you'll see on one of the other slides, I'm an executive sponsor of this, but it'll be Toby's Innovation Showcase. So Toby is a general physician at the Northern Adelaide Local Health Network, or NALHN, and is currently the divisional director for the Division of Medicine. Toby has a keen interest in digital health with a passion for quality improvement. He believes that the future of medicine will involve greater face time between doctor and patient, and the better use of digital tools will remove cognitive load and facilitate enhanced patient-physician interaction. Over to you, Toby.
Thank you very much, Tina. So I'll be talking to you today about a very specific project that it has been my pleasure to be involved with the CIH, particularly Tina as my co-executive sponsor, and Bonnie Langtree, who's been the driving force, and some just great data people as well, to see how we can turn the data that we have in our system and actually use that to become knowledge and drive improvement. Just to give you a bird's eye view of where this came in, so there was a grant given from the MRFF that has been administered by the CIH back when Derek Chu was the commissioner. It was about acute care, and it was split into four projects. The first one being pre-hospital care to do with chest pain, inpatient care, where we really wanted to focus on general medicine and variation in care, which I'll get to in a moment, and then the transition of care out. So what I'm going to talk to you about is project 2 of that. And really, project 2 was focusing on general medicine, largely because it was acknowledged that with such a large swathe of the bed base in South Australia, that if general medicine isn't working well, then the system gets stuck, and we frequently get stuck even if general medicine is working well. But we wanted to look specifically for variation in care. No surprise, that's why you're here. But we wanted to look for variation in care. Why? Because usually where there's variation in care, there is a target for quality improvement. You know, that's sort of classic QI methodology, that if there is variation, probably somebody's doing it right and probably somebody else could improve. And so we wanted to look at that. And specifically within the grant, we were looking at using AI, and this has gone back a few years where AI was considered very futuristic. And particularly looking at machine learning to derive algorithms that may help us reduce variation in care. It was a good opportunity to engage general physicians particularly, and I say this as a general physician, sometimes we can feel like the foot soldiers of the executive arm of the health system, and frequently there are things being done to us and not necessarily with us. We feel like, and maybe this isn't correct, but that we don't maybe have the agency of some of our subspecialty colleagues. And so an important part of this process was going to be to ensure that this was general medicine coming up with issues where we felt that there was variation in care, where we felt that there could be an improvement, and really use it as a springboard for that engagement, where we can have those discussions. As you know, we're sort of a very large group of clinicians, but we don't necessarily sit in a room together and put our heads together all that frequently as other specialists might. So we decided to undertake an approach whereby we would explore the issues, and then we would whittle down the number of issues down to a manageable number that could be which we could use machine learning to help improve. And then we would derive algorithms and implement those algorithms that are going to help reduce variation in care. We are at a point along that journey, which I'll take you through. We have not yet executed on that full plan, but the more people who know about it, the better. So we had two main ways we were going to explore the data, and again, clinicians can be very solutions focused, and so we very much deliberately wanted to make a deliberate exploratory phase before we started to look for solutions. And there was really two ways of doing this. One was to look at the data, and so typical things, start with the DRGs. I never find that that's a very useful way to start any project. Look at the DRGs, look at the bed days, but there were certain diseases that really stood out as being very common and likely having variation. So we would suggest those and do an exploration, but bring the clinicians with us. And indeed, there is no general physician who would contradict you when you said that pneumonia, heart failure, COPD aren't key issues in general medicine, right? That's what our beds are full of. But using the clinicians to validate that, and then parallel to that process, have the clinicians come up with those issues in a semi-structured way, so that we could explore the issues that maybe don't jump off the page from a data point of view, that we would have plumbed several times before. And So this is what the clinician engagement process looked like. And again, to reiterate, the idea here was to go through an organic process whereby we would identify issues. So we started off with workshops in the 3 LHNs, starting with NALHN, CALHN, and then SALHN. And so we would have we would have a workshop, which I probably shouldn't say it, but something that I would describe as a curated whinge with my general medicine colleagues. Really, you know, the first sort of 20-30 minutes was convincing them that we weren't trying to do anything to them, that this was about them. Well, when we have the data, what are you going to make us do? Nothing. It's your data. It's what do you want to do with it next? Once everybody settled down, there was a way of facilitating the workshop so that we could come to questions, and ideally at the time, if not afterwards, come to questions that could be answered using the data that we have available. Some of the questions are hard to answer with data. For instance, workforce, you know, how senior was the reg on that day? That's really hard. We don't have great data around those things, but there were lots of topics where we could steer the conversation to come out with a question that could be data focused. The next thing we would do is put that in a data socialization tool. And I'll talk about that in a moment, but that was a way of reflecting on the data that we had pulled so that we could then go back for another workshop and say, hey, you asked this question, here's what we've got. What do you think of that? Have another discussion about where we might otherwise find variation. And then we came up with a list of several issues. And then the process was whittling that down into something manageable. So this is a visual representation of what we ended up with, which was 90 ideas. And we had to whittle them down to hopefully a sort of manageable, maybe mid-single figure number of ideas. And so we had, and that's the process we are nearly at the end of. So at the end of those, that process of having workshops, data socialization tool, more workshops, we've managed to whittle them down so that we've taken out any that are out of scope, anywhere where there's not a really good data answer, or they might be really interesting, but there was no variation identified. But we still sort of want to keep those in our back pocket, because for things like advanced trainee projects and things, they're actually very useful ways to interrogate the data that we have, and we still want to pursue them, just not in this particular project. And then finally, yes, there's it's a good question, it's good variation, but will a machine learning algorithm help with that? And what we want to end up with is valid machine learning use cases where we can use algorithms to hopefully influence the care we give. So this is what we would start off with at the start of a workshop. That is a blank slate using the mural board. And what we would have is Bonnie and Georgie would be frantically writing down as I'm trying to facilitate the workshop and trying to direct the questions towards those pain points and those issues that we know exist that we haven't otherwise looked at, and try to and hopefully towards a data-driven answer. And so what we would end up with is a very full mural board, and this would go back to CEIH, and this would be curated and themed. And what we would end up with is a data socialization tool. Now, what is a data socialization tool? It sounds very fancy. It looks like a dashboard, but we were very keen not to call it a dashboard, not just because people get antibodies to the term dashboard, but also because a dashboard is sort of a tool for monitoring how you're going, whereas this was particularly to demonstrate to the clinicians that got involved in our workshops that we can actually answer questions using those data. It's a univariate analysis. It's just, it's counting things and putting them on a dashboard, but it was a great way of visualizing the answers to the questions that have been asked, so we could then go back to the workshop a second time and sometimes a third time and keep refining those questions. So I'll give you an example. So end-of-life care was one of the ones that really jumped out at us and has gone through that funnel process, and we do think that it's a good use case. And so we had the initial workshop, and we started talking about end-of-life care variation, and then this classic thing about, you know, over servicing people who are going to die soon, and you know, we spend an awful lot of money in people's last year of life. Is it high value care? A lot of it's not avoidable. We're not saying it's avoidable, but is it high value care? Is it that different decisions might be made if it were obvious that if the patient's life expectancy is short? And those could be decisions about healthcare itself, investigations, treatments, but it also might be about end-of-life planning, for instance. And so we spoke in the workshop about whether, you know, about end-of-life care discussions, you know, about when we make people not for resuscitation and so on. And so we had the workshop. We came up with a mural board that was full of questions, such as the one there, end-of-life testing, and we over-ordering. We popped it on the data socialization tool. And we try to come up with, again, data-driven questions. So how often are patients getting tests in the last 12 months of life? How well are we using EMR to record end-of-life planning? When are patients having their, for instance, their resuscitation status going from for CPR to not for CPR? These are all questions that we can answer with data. And so we found out that 45% of patients who died with a not for CPR order had that changed from for CPR to not for CPR. 45% of them was within the last 7 days of life, which we were surprised by. We thought that it would be been predicted much further before that, and indeed that represents variation in care, because if in general medicine mortality is predictable from a long way out, which it tends to be, unlike perhaps in something like surgery, is that something we could improve? And so we have hypothesized, and I'll say end of life works very well from a machine learning point of view, because it's a very defined binary outcome. And so, you know, that is well recorded in the data. That is to say, patient dies and we have a time and a date for that. And so we went through the process and we decided that this was a good opportunity to use machine learning in order to anticipate when a patient might die. Now, what we're currently doing on this topic is saying, well, what kind of a tool do we want? Do I want this patient's actual life expectancy and a single number? It's 6 months? No, because that's meaningless in medicine. 6 months could be, well, there's a 90% chance of dying between 3 and 9 months. Do I want, what's their chance of still being alive in 1 month, 6 months, 12 months? So these are the kind of questions we're currently asking. What would if we had a tool, what would that tool look like? And then once we have the tool, then will we decide how are we going to use it, or how are we going to monitor whether it's working? This is an exploratory process. It is not the classic scientific process of saying, well, let's come up with a really solid, well-defined research question. This is the organic development of that research question, rather than it coming straight from a, you know, oh, professor, this is what your last paper showed. What should your next paper demonstrate? And so we hope to develop an algorithm, which we don't know what it's going to look like, then test the algorithm, which we don't know what that's going to look like, and then write it up. There is that excellent paper there that I hope is more legible on your screen than mine, but that was using exactly this sort of thing to estimate whether somebody was going to die within the next 3 to 6 months in order to generate palliative care consults for the palliative care team in Stanford to do better work. Once we've got the studies that or the questions that we want to explore, there's sort of been congealing over the last maybe 5 years a way of reliably deriving and testing your algorithms to ensure that there's robustness there. And so that's been tied together in something called the salient framework. the process will not be a surprise to anybody who's been looking at machine learning algorithms over the last 5 years, but what we will adhere to this framework. And so what it looks like is you will derive your algorithm. That's always on retrospective data by definition, and you might use 80% of your retrospective data to derive it and test it on your last 20% to see if it works. But we need to actually test it prospectively. So we'll test it retrospectively, then we test it prospectively. That's often known as a silent trial, where we will look at real patients. We will see what our predictions are, then we see what the outcome actually is. So for instance, for end of life, that would be, we predict that this person may die by this time, and then we see when it actually happens. That's a prospective validation study, or what's increasingly known now as a silent trial. That will be the end of this grant-funded project, but then now you've got a tool that you know works prospectively. It's how do you actually roll it out? And so you would pilot that in an area to see if you can affect the care that's being given. And then ultimately for us, we really want to see, can we reduce that variation in care? I'll rattle through a couple more examples of things that we've done just as part of this project. So pneumonia and COPD are the two biggest DRGs for general medicine units throughout the Western world. And we've done quite a deep dive. We've now got 2 documents, one for each of those pathologies that run to the best part of 100 pages each, with lots of information and lots of detail where we have variation in care. So we've had lots and lots of inter-hospital differences, and we've been socializing those data with general physicians and respiratory physicians in ways that should hopefully lead to quality improvement projects that will reduce variation in care. Heart failure is another enormous one, and cardiology takes care of a certain kind of heart failure. Usually it's heart failure with reduced ejection fraction. Usually it's more monomorbid. The gen med patient tends to have the kind of heart failure which you can intervene on less, with other comorbidities that mean that they can't necessarily get guideline-driven therapy. And so we've done a good exploration of that. We didn't find any machine learning use cases therein, but again, we've now got a very reasonable document that demonstrates what we do. And the one thing that we fell down on here and that we would love to have help with is that echocardiograms reporting, which is, it's not pictures, it's just a bunch of text, will tell us what kind of heart failure there is, but they use on different systems and different LHNs, and we couldn't for this project pull it all together and actually parse those different echocardiogram reports, but we are certain that with those data available, that this sort of work would be a lot more meaningful. So if you've got insights into that sort of thing, please let us know. Sepsis is the other one that we that came out very early. Not that it takes up a huge number of bed days, but it is probably responsible for quite a proportion of our preventable deaths. And we do think that early detection of sepsis is good, and getting treatment in early is good. Previous algorithms for or previous tools, let's say, for detecting sepsis tend to be very, very sensitive. It's not going to miss anybody with sepsis, but it's going to take a whole bunch of other people into that net. And so we were hoping to get a tool that is better than the current scoring system, so QSOFA or SIRS, for detecting sepsis that is both sensitive and specific. That is to say, it's got everybody with sepsis, but it doesn't take in a whole bunch of other people with it. And indeed, we have a tool that looks like it's going to perform an awful lot better. And if that could develop into a tool that, for instance, a clinician might get a prompt to say, hey, I think this patient got sepsis. You don't seem to have written that word in your notes or prescribed antibiotics. Would you consider doing that? And with hopefully to prevent those preventable deaths. That's it from me on this topic, but happy to get questions.
Thank you, Toby. I think no clear bias at all when I say fantastic work.